Welcome back to another Deep Dive Explainer. Today, we're slipping right into the diagnostic shoes of a clinician to solve a surprisingly common medical mystery. We're looking at two very prevalent gynecological conditions, moniliasis and atrophic vaginitis. Now, on the surface, the patient complaints sound incredibly similar. But if you look beneath the surface, they are driven by entirely distinct biological mechanisms. It's like a giant puzzle. So let's learn how to decode the clues, separate the symptoms, and uncover what's really going on.
So you might be wondering, why is accurate diagnosis absolutely critical when symptoms overlap like this? Well, in gynecological health, vaginal discomfort, things like itching or burning, is a practically universal symptom. When a patient comes in with these complaints, it is so incredibly easy to just make a blanket assumption. But think about it. If a clinician treats an infection when the actual issue is tissue atrophy, or vice versa, the patient doesn't just continue to suffer, the underlying condition can actually get worse. Identifying these specific clinical clues isn't just about getting the chart right. It prevents misdiagnosis, avoids totally unnecessary treatments, and immediately gets the patient on the path to proper, effective care.
Okay, let's dive into this. Here is our roadmap, basically our patient chart for decoding these clinical profiles. First, uncovering vaginal health profiles. 2. Moniliasis and its predisposing factors. 3. Diagnosing moniliasis accurately. 4. Atrophc vaginitis clinical features. And finally, number 5, clinical profiles, key takeaways.
Section 1. Uncovering vaginal health profiles.
And what's really interesting about this is how clearing up basic definitions right off the bat immediately reduces the cognitive load for clinical diagnosis. Just notice the stark contrast here. Moniliasis, which you probably know better as candidiasis or just a standard yeast infection, is fundamentally a condition of overgrowth. It's an active fungal infection caused by an imbalance in the local microbiome. But on the flip side, atrophic vaginitis isn't an infection at all. It's a condition of deficiency. We're talking about the thinning, drying, and inflammation of the vaginal wall specifically because of a decrease in the hormone estrogen. So right away, we are dealing with two entirely different environments. One is an overgrown ecosystem, and the other is a totally hormone-deprived landscape.
Section 2. Moniliasis, the predisposing factors.
To truly understand moniliasis, we have to look at the environment that actually allows it to thrive. These are our first set of clues. First up, broad-spectrum antibiotic use. Antibiotics basically wipe out the healthy, protective bacteria, like lactobacillus. This creates a vacuum, and yeast will aggressively multiply to fill it. Second, uncontrolled diabetes mellitus. Yeast literally feeds on sugar, so high blood glucose means higher glucose in vaginal secretions. It's basically an all-you-can-eat buffet for the fungus. Third, elevated estrogen states. Think pregnancy, or maybe certain oral contraceptives. These alter the vaginal flora and increase glycogen production, which again feeds the yeast. And finally, immunosuppression. This just lowers the body's natural defense mechanisms against opportunistic fungi. If a patient presents with discomfort and checks literally any of these boxes, moniliasis absolutely jumps to the very top of your differential diagnosis.
Let's move to Section 3 and see how this builds, diagnosing moniliasis accurately. Okay, let's walk through the exact, step-by-step diagnostic features required to accurately identify this overgrowth in a clinical setting. Step 1 is usually the primary patient complaint itself, intense pruritus, which is severe itching, along with erythema, that's the clinical redness and swelling of the vulvovaginal tissue. Then, Step 2 is your hallmark physical sign. You're looking for a thick, white, clumpy discharge. It's classically described in medical literature as having a cottage cheese-like consistency. But Steps 3 and 4, that is where true clinical confirmation actually happens. Step 3 shows that despite those severe symptoms, the vaginal pH actually remains normal and acidic, so typically less than 4.5. And finally, Step 4. This is the gold standard diagnostic step, a microscopic wet mount using potassium hydroxide, or KOH. Under the microscope, the clinician will literally see the fungal architecture right there, the pseudohyphae and budding yeast spores. Following this step-by-step approach guarantees precision.
Section 4. Atrophic vaginitis clinical features.
Pivoting to our second condition, we start a parallel track of investigation, and we immediately notice a very, very different patient experience. We really need to maintain an empathetic approach here, because this condition profoundly impacts a patient's quality of life, and it's often chronic. Unlike that intense, acute itching of a yeast infection, atrophic vaginitis presents primarily with chronic vaginal dryness and a really deep burning sensation.
This naturally leads to dyspareunia, which is significant pain during intercourse, basically caused by the incredibly fragile state of the tissue. When you do a clinical examination, the objective signs are clear as day. The mucosa isn't red and swollen at all. Instead, it is visibly pale, thinned out, and delicate. There's also a noticeable loss of vaginal ruggie. Those are the normal mucosal folds that actually allow tissue to stretch. It just becomes smooth and easily traumatized. And here is the absolutely crucial part for diagnosis. The vaginal pH is elevated, usually greater than 4.5. Why? Because a lack of estrogen literally means a lack of the healthy bacteria that keep that environment appropriately acidic.
Section 5. Clinical Profiles. Key Takeaways.
And this brilliantly illustrates everything we've been talking about. By putting these clinical profiles side by side, the differentiating factors become instantly clear. If you are trying to tell these two apart in real time, just compare the metrics. Look at the pH. Moniliasis is normal and acidic, while atrophic vaginitis is elevated and alkaline. What about the discharge? Well, moniliasis gives you that thick, clumpy white discharge, whereas atrophic typically features minimal, thin, or even watery discharge. The primary symptom complaint completely shifts too, moving from intense, acute itching in moniliasis to chronic dryness and burning in atrophic vaginitis. And structurally, you're looking at red, inflamed tissue versus pale, thinned-out tissue. Honestly, this is your ultimate diagnostic cheat sheet.
So the crucial point is this. The clinical necessity of differentiating these two conditions isn't just some academic exercise. It is entirely functional. Their distinct profiles demand totally distinct treatments. You absolutely cannot treat estrogen-depleted, thinning tissue with an antifungal cream. It will likely just irritate that fragile tissue even further. And on the flip side, there's no way you can treat an aggressive fungal infection simply with moisturizers or hormone therapies. Recognizing these highly specific clinical features and predisposing factors is literally the only way to deliver targeted, effective relief.
To wrap up our explainer today, I want to leave you with this thought. How does understanding these distinct clinical profiles change our approach to diagnostic assumptions in women's health? When we see how two conditions with such overlapping initial complaints can stem from wildly different root causes, it really highlights the danger of clinical guesswork. It challenges us to ask better questions about predisposing factors and to rely on objective diagnostic features rather than just making subjective assumptions. Thank you so much for joining me for this focused explainer. Keep analyzing those clinical clues, and I'll see you in the next deep dive.